All right. So, hey guys, welcome back. We are now live in the 5-day EKG challenge. With our special guest, it looks like we do have some people from Chart in the house here to represent and say hello to our guest, Joe. So, just as we're getting ready to get started, I wanted to remind everybody as we're lining up, Regina's giving you a hug. As we're getting ready to go, we do have, this is our fourth night, right? We only have one more night left tomorrow night, 5:30 Pacific Standard. And just a reminder, in about halfway through Joe's session, he's going to give the floor back to me for a moment. I'm going to tell you the hashtag to win our scholarship. Again, you're only eligible if you're live. So for those of you who are live, lucky you. If you have questions for Joe, Joe, do you want them to post them as we go, or do you want them to wait till the end?
I would say wait till the end. I throw them either one. Doesn't really matter. If it's a quick one I can answer, I'll answer it. If it's more detailed, we can tackle it in the end or in the chat afterwards.
Awesome. All right. So, Joe, why don't we, for the next few minutes, if you don't mind, why don't you tell us a little bit about yourself, your background, kind of what you do, and then maybe you can jump into starting your session.
Yeah, that'd be great. Appreciate it. First of all, thank you for having me here. I feel like I'm part of the Cool Kids Club now, being on your stuff. I've been following you for like the last year. Regina Keeper, a mutual friend of ours, introduced us, and I've been following your social media teachings for quite some time. And I love the passion and energy in which you teach. I saw you the other night. I saw Gary with all the animations. So I feel like I have a large, high bar to reach with you folks, but thank you for having me here. As far as my background, it's really interesting. I understand we have a lot of EMT, paramedics, early nursing career folks here, along with some advanced nursing. So I originally started off as an X-ray tech. Went through X-ray school, got introduced to the cath lab while I was in school and fell in love with the cath lab. I got really bored of just pushing buttons and saying, hold your breath, don't breathe. And when I got into the cath lab, I just fell in love with it. Along the way, I became an EMT, started to really dive into ECG. And along with probably a lot of people here, it's really hard at first. It's like learning a different language, learning to read these boxes and these waveforms, and it's something totally different. You're reading all these words in a book and trying to figure out what it's really trying to say and trying to create this word picture in your mind. So along the way, as I was a cath lab RT, I got my EMT so I can get into nursing school. Went and got my nursing degree after that, and got exposed to something called cardiac electrophysiology in like early 2000s, and loved it. And didn't know what I was looking at. And it was really weird because I worked with the nurse in LA at the time that wouldn't really show me or teach me this stuff. And I had just this desire and this sort of just chip on my shoulder to learn this stuff. And along the way, I just had this insatiable desire just to learn as much EP as I can, because what it is, it's taking what you study in EKG and where you look at it at 25 millimeters per second. Now we're looking at it at anywhere from 200 to 400 millimeters per second. And then we're not just looking at 3 waveforms, we're looking at sometimes 20 plus waveforms, and we're trying to dissect it out. And what we're doing is we're measuring all the different components of the heart and really looking what we learned as normal versus what you do in ECG abnormal, right? It all starts from learning normal first. And then from there, you can be a supportive member of the team, looking at the waveforms, running the ablation units, which is the way to burn the bad circuits to restore their normal heart rhythm. And so, yeah, that's been sort of my journey. X-ray tech, the EMT, to nurse, dove headfirst into EP. It took me a while to learn it. And now we're here. And now I teach it and work with some folks here at Chart Healthcare Academy that are very passionate about it. And they look up to you, Jen, the way that you teach it. You have some great mad skills, and we learned a lot from you and really appreciate the opportunity to be here.
I love hearing that story. It's really motivational, Joe. And obviously respect is mutual. And I know that a lot of folks are really looking forward to your EP brain, how you kind of can show us how the heart connects to what we're seeing on the page. So that's, I think, the biggest mystery for people. So we're really grateful to have you on. So looking forward to the session. Again, if you guys have questions for Joe, then pop them in the chat. He can see them on Zoom. And we'd love to have you on Zoom so that you can interact with us. It's more fun that way.
Great. I'm going to go ahead and share my screen. And as I do that, if I can get everybody who's on to sort of tell me what your background is, if you're like an EMT, and then what you're looking to go into. And if you don't know, just say you don't know. Or if you're a nurse and you want to get into being a PA or an NP, or in what field do you work? I'm curious to see on the feed who's where. That might give me some more information to work with here. Meantime, I'm going to set up my screen and let me know if you can see it. Are you seeing, what screen are you seeing? Are you seeing where it says Chart Healthcare and then my name in like a electrical thing on the bottom?
Yep. And we already have some people in the comments telling you what they do.
All right, awesome. Let me bring up my chat so I can see that. Awesome.
Looks great, Joe. Jen said I could unmute for a second, so I just wanted to say, hey to the crew.
Hi,
my
Regina.
buddy here, my buddy, love her Regina. She's fantastic. Awesome. Okay, so I'm Joe Giron with Chart Healthcare Academy. I'm going to forward here to the end of the deck because people don't really know what EP is. We have a lot of people here who are just starting out in PA school. That's fantastic. We got some CVTs, nurse practitioners, ER, RNs. So we got a pretty good mix here. So for those who don't know what EP is, hopefully I can give you sort of a background to what EP is and let you know what happens behind the scenes there. And so I have a couple goals here. One is to kind of create a word picture for all the different things you've been studying in EKG, the waveforms. You're looking at, Jennifer's doing a really good job of helping you identify atrial signals, ventricular signals, and how they coordinate. And she's got some really great colorful language to help you remember some things. So what I want to do is bring in a series of sort of graphics from an EKG point of view and have you sort of create that word picture in your mind so you can better connect the information that you're learning about to read on the EKG and how it translates from a physiological point of view, from an anatomy point of view, because I think that'll help you to really understand. And so for those of you who are maybe in paramedic school or EMT school or nursing school, and you're looking at this going, I got to learn this because I need this to get to where I got to go, but you're not too excited about it. I'm hoping by the end of this that you see the heart in a different way, in a way that you go, okay, so if I really master this EKG and it starts here with learning it on a basic level, that you can get into 12 lead, then maybe you might consider going into something like electrophysiology. Because I got to tell you, the more I learn about the heart, the more I just want to learn more about it. It's fascinating, the way it's designed, the way that it works. The backup systems, when one system fails, like the SA node, the AV node kicks in, the AV node fails, other things kick in. It's just really fascinating to me to see how it all works. And so I want this to be sort of a collaboration. I'm inviting Jen to sort of add some color commentary to things that we discuss here to bring it back to EKG. At the end of the day, that's what we're doing here for you folks. And then to invite you to consider possibly a career into cardiac EP because COVID has decimated most industries in healthcare, nursing, obviously, and then EP is no different from everybody else. So that's what we do. And I'm going to show you sort of where it all starts out. So I'm going to go here to this slide. This is what we work with when we're in EKG. We're in EP. So imagine you're scrubbed in with a physician, or you're in the control room, or you're a rep facilitating some of the equipment, and you're looking at all these monitors. So the physician, he or she, only has 2 eyeballs to really look at what's happening here. 1, 2, 3, 4, 5, 6, 7, 8, 9 monitors. So this is where all hands need to be on deck inside the EP lab. You can see there the screens. You have your surface ECG leads here at the top, and you get all these other squiggly lines here at the bottom. And that's what we're learning to interpret in electrophysiology, is make sense of this information. So when you really master EP, you get to sit down in a lab like this and run this equipment. So again, here's your EKG. We call this the EP recording system that collects that. And then along the way, you have something called a 3D mapping system. So if you ever get tired of working in patient care, then you have the opportunity to work outside of patient care as a vendor rep, supporting a lot of that mapping technology. And what that's doing is creating a live 3D model of the heart, and you're helping the physician navigate around the chambers of the heart so they can evaluate the different pieces of the conduction system, see if it's normal versus abnormal, find the bad circuit, and then go and ablate or burn the bad circuit. So for me, I grew up, I hate to say this, I'm going to date myself with Nintendo, right? Like that was my video game as a kid. Now these kids have crazy games, but to me, EP is like this big giant video game operating this equipment where the patient wins, and you get to work with smart people, air conditioning, wear scrubs, get paid very well. So for me, I'm just a big advocate for it. People don't know about it. So if I can turn people onto it, that'd be great. And it all starts with learning what Jen is teaching you, the foundational pieces of it, which is ECG, and then 12 lead beyond that. So this is what it looks like. This is what I usually close with. So you could be this person here. Hold on, this is not a timer. You can be the person here scrubbing in, or you can be the person here running the map, and that's the EP lab. So let me go back to the slide that Jen, you have identified for us to work through. And this is slide 7. So you guys all know this, right? This is the cardiac conduction system. Jen's done a really good job of telling you how When certain pieces of it depolarize, you get this wave deflection or this morphology. So if I can get inside the chat, some people to type in what those different letters correspond to on this screen. So what is A? If I can get in the chat, what is A? And the reason why we're doing this exercise is because what I want you to really do is to burn this image into your mind, because the more that you kind of create these word images, that's right, SA node. What's B? So the more that you kind of burn these images in your mind, the more that you can recall this information, these abstract ideas, and look at the morphologies and start to connect what's happening physiologically with the anatomy. That'll really help you to really understand and cement the concepts that you're learning, because it is hard to learn at first. So B is your intra-atrial tracts. You have 3 or 4 of them, depending on which ones you want to count. And those all feed into the AV node, which is their C. So C is the AV node. So think of these tracts as super highways that they have increased conduction velocity. If you haven't heard that term, again, this is all part of being exposed to EKG, into electrophysiology. You're learning this new language. And so everything beats or propels electricity at a certain speed. So these intra-atrial tracts are like super highways, allow you to go faster than you can on the streets. So those all bring it back into the AV node. So if C is the AV node, what is D? D is kind of an important structure, really important in electrophysiology. And I'll explain why in a second. All right, His, bundle of His bundle. Yes, bundle of His. So the His bundle is the only fiber, and this is going to make sense a little bit down the road, that connects the atrium with the ventricle. There should be no other connection between the A's and the V's. The atrium is protected, or the ventricle is protected from the atrium by something called the fiber skeleton, which electrically isolates both the A and the V. If you ever wondered why the A beats and doesn't directly go down into the V, it's because everything has to go through the AV node, exit the AV node, in through the His bundle, and that's what pierces the fiber skeleton into the ventricle. So when you have an extra pathway, like we talked about the other night, Jen talked about WPW, that is a syndrome where somebody has an extra pathway that connects the A and the V, and that's where we get into some really weirdness, different arrhythmias. So normally you should only have one pathway, and that's your His bundle that pierces the fiber skeleton. So below that, you have here in red, what would red be? You have, depending on how you look at it, 2 major ones, 3 major ones, if you will. What is highlighted there in red? It goes to 2 to one side, 1 to another. What would that be? I know Jen covered it. Yes, right and left bundle branches. That's right. So the terminal end of the conduction system, for my cath lab friends, you know what this is, because every time you put the pigtail into the ventricle, it causes a PVC because you rub these. And the Purkinje fibers. Yes, awesome. So that's a conduction system. Please, please, please burn this image into your head, because you're going to reference this as you go back to what you do in ECGs and 12-lead ECGs. So this is setting up to what you recognize as normal. So when everything works normally, when you have normal sinus rhythm, you got to be able to understand what that is right out of the gates, because you can't really differentiate abnormal unless you have normal. So we're going to go through each section here, talk about each piece of the connection system a little bit more, sort of show you what the ECGs are that sort of, tied to that. Here we have the SA node. We talked about it. That is the primary pacemaker of the heart. It generates electricity all on its own. And so that beats anywhere from 60 to 100 beats per minute in the normal adult. For kids, it's a little bit faster. And so from that, we have our normal sinus rhythm. That is your SA node. It gets regulation from the autonomic nervous system. For those of you who aren't familiar with it, the autonomic nervous system is broken up into really 2 pieces. You have your sympathetic and then your parasympathetic. So I like to think of it like this. Your sympathetic is really your fight or flight response, right? So if you see a bear coming at you, you're either going to run from it or you're going to fight the bear. Why you want to fight it, don't know. But that's where the sympathetic kicks in, and your heart rate races, your pupils dilate, blood pressure goes up, gets you super excited. Well, your parasympathetic is your more evolved side of your nervous system that says, hey, bro, calm down. You got this. You just got to run faster than the slowest person. And so that's your parasympathetic kicking in. So your SA node is regulated by that nervous system. And obviously the stimuli that comes into the nervous system affects how fast your SA node works. So we talked about intra-atrial tracts. We talked about this earlier. You have 3 of them. You have your anterior, medial, and posterior. Again, those are like super highways that feed into your AV node. Here we have a nice animation here to kind of highlight what that is inside the heart, trying to give you sort of a 3D perspective of the heart. Then here we have your you have Bachman's bundle, which connects from your SA node all the way over to the left side of the heart as well. So again, this is that superhighway. That's how you get the left and the right to both, beat with synchronicity. So that's Bachman's bundle. The AV node. AV node is really fascinating. This is one of the things that really just got me thinking in EP. So it's considered the gatekeeper, right? So that's what regulates information coming in from the left atrium, and then it sends it out to the ventricle. So it's really interesting about the AV node, and you get a lot of different arrhythmias from the AV node when it gets disrupted to a degree. So what it does is it regulates impulses from the atria into the ventricles, but it also serves as the backup. So when the SA node goes down, and you'll start to see a pattern here, and that different components of the conduction system will kick in with intrinsic rhythm, but the further down the tree you go, the slower the rate is. And you can't maintain an optimal cardiac output when you're starting to depend on the AV node or the His bundle or the Purkinje fibers beating, sustaining an optimal heart rate, because it just can't. In this case, the AV node is anywhere from 40 to 60 beats per minute if the SA node gets knocked out, which is why when the SA node gets knocked out or doesn't work right, then you're looking at a pacemaker to make sure that we can maintain effective cardiac output. So what's really interesting about the AV node is it has something called decremental properties. So the best way to describe that, it's a phenomenon in the heart. Basically, just think about AFib, right? You guys have studied AFib, you guys have studied flutter, right? So what is that? That's when the atria beat really, really fast. And it beats so fast that if it was to translate into the ventricles on a one-to-one basis, then your cardiac output, meaning the amount of blood that your heart puts out, would be lowered, and it's just not sustainable for a high level of high functionality of life. So what the AV node does, I like to think of it, nothing against those of you that work for a union, but I like to think of it like a union shop, meaning the harder that you tell the AV node to work, it said, no, I'm going to regulate the level of work that we do here because I got to protect my ventricle downstream. If you tell me to work too hard, then I'm going to start to take a break and slow things down. So what's interesting is the faster the heart rate goes up in the atria, the AV node starts to slow it down, and you start to see a long PR interval take place. And this is where you get into Winky Bach, right? You talked about Winky Bach, and this is where the heart starts to go really fast. So it slows it down, slows it down, slows it down till it finally says, I ain't taking this anymore. I'm going to drop a beat so I can let the ventricle catch up and maintain a higher level of cardiac output. So that is the AV node. Decremental properties. We do a lot of study in EP around how well this phenomena works in the heart. So that's the AV node. The His bundle, again, is a very important structure. It's the distal end of the AV node. It's what pierces the fiber skeleton from the atria into the ventricle. And that's what allows electrical communication between the atria and the ventricles. When you damage this is when you get some level of delay or block. Same thing with the AV node. If you damage or have any kind of disease involving the AV node or the His bundle, you get a level of block, and the further downstream it is, the more severe it is, and the more pronounced your EKG is going to be as far as that's concerned. So that's the His bundle. We measure the His bundle in the EP lab because we cannot measure the SA node and we cannot measure the AV node because of the way that they depolarize. They have different ions that depolarize those. So we're not able to measure those unless it's depolarized by the sodium potassium pump. So we can measure heart tissue depolarizing, but we cannot measure the SA and AV node. So we have to go and measure the His. So when we measure the His, it tells us what the AV node is doing. So a pretty important function of the heart and EP as well. So this is what's responsible. Correct me if I'm wrong, Jen. This is what's responsible for our junctional rhythm. So, something I've been in EP so long, I'd love to kind of have you add some color commentary to this piece of it. So why is it that some junctionals have a wide complex compared to a narrow complex, not including a bundle branch block? Is it the level of the AV block where that takes place, why you have a wide versus the narrow? I was wondering if you can sort of add some color to that.
From my understanding, it has to do with where the actual site is coming from. So the closer it is to the ventricles, the wider it is. Is that what you understand from your EP standpoint?
Yeah, when I look up junctional, I was doing a case study the other day, and I was looking at junctional rhythms, and sometimes they're wide, complex, sometimes they're narrow, and I believe it has to do with how low down either the AV node or the His bundle the block occurs or the delay occurs. Meaning, if it's depolarized by the ventricle, then you're going to have a wider complex as opposed to higher up then it goes through the His bundle normally, but there's some sort of blockage or delay up top. And you were talking about that the other night, actually.
Yeah, and the interesting thing about this is that sometimes the P waves will be inverted, sometimes they'll be retrograde, and sometimes they'll just be absent. And so the key, I think, for diagnosing if it's a junctional rhythm is really rate and the presence or absence of the P wave, or the shape or direction of the P wave. That's totally critical.
Yeah. So we're 15 minutes in. He said he wanted me to pause for a second to talk about something.
For
Yes.
reminding me, Joe,
Yes.
I almost forgot. You guys, so you're going to put hashtag in Zoom and Facebook if you want to win the scholarship to our 30-day EKG challenge. When Joe's done with his session, I'll be drawing your name. So I'm going to be watching the chat feed right now, and I'll be writing your names if you want to win the scholarship. So hashtag 30-day, and I'm going to turn the floor back over to you, Joe.
Thank you. We got 15 minutes. I'll try and plow through as much as I can. Hit some funner stuff here downstream.
This is awesome. This is so great.
Left bundle branches, depending on which one is blocked, you'll either have your rabbit ears in either V6 or V1, either upright or depressed. I know that's more advanced ECG, but what causes that is having a bundle branch block. So real quick, have you talked about aberrancy at all in your class so far? What aberrancy is?
Actually, we did on WPW. We showed a tract, and we also put a reel up today with a great EKG that you would like in the 5-day video EKG group of an AFib with RVR that had an underlying WPW. So they've actually been exposed to this concept.
Awesome. I'm going to come back to that, which is why I asked the question. So, and it has to do with a level of block there. So, and then you have your Purkinje fibers. Again, if you have to depend on your Purkinje fibers firing away, that's at 35 to 40 beats per minute. This is where you get your idioventricular rhythms that Jen talked about earlier, and that's what's kicking those off. So that's the conduction system. I'm going to go on down here and talk a little bit more about Brady versus tachy here. So we covered tachy, which is slower than 60. So why do we have tachycardia? So it's a result of one of two things. It's either a failure of impulse formation, meaning the SA node is not generating enough stimulus to drive the heart rate, or two, failure of impulse generation, which is some degree of block or delay. As opposed to tachycardia, the mechanism that causes tachycardia are much different. And this gets into the arrhythmias that we're more prone to seeing, right? What we're being tested on, you got your AFib, you got your flutters, you got your AV NRT, not to be confused with your AV RT. And EP, you'll learn really quick that we love to use acronyms for everything. So I'll try and explain away as much as I can, but everything just gets to get longer. So it just works more efficient when you can use acronyms. So we'll dive into this a little bit deeper. So again, getting into Brady arrhythmias, and I know you covered a lot of this, Jen, sinus Brady, sinus block, sinus arrest. So these are all going to be one of two things that cause it. It's going to be either a failure of impulse generation, meaning the SA node is not sufficient, or there's something happening between the SA node and the AV node that either involves the interatrial tracts, the AV node, something feeding into the AV node, something at the AV node, or something below that. So this is where you'll get your conduction delay. We have the different types of conduction delays, and then we have our escape rhythms. So those are all mechanisms that feed into bradycardia. You're talking about ischemia, metabolic issues cause that. It's a variety of different things that can cause that. We don't worry about bradycardia so much in the EP lab. In the EP lab, we're worried about the faster tachycardic heart rates, because if they're slow, then they got medications that they can get on, or they can get a pacemaker. So, which we do that in the EP lab, but I don't know anybody in EP that gets excited about pacemakers too much. So the severity of failure has to do with where at, as we talked about earlier. We have first degree all the way down to third degree, and as Jen talked about, if it happens higher up the conduction system around the AV node, then it'll be less severe. The further down you go, the more severe your block is going to be. So anything you wanted to add to that piece of it to kind of tie it in, Jen?
No, I think you're actually, come to think of it, it's like you're reading my mind. There is a quick heart block video that I talked about a couple days ago that's in our 5-day feed that goes over these in like 2 minutes. I draw it out on a board if you want to practice it. So you guys are going to be heart block experts after that and between Joe's lecture, but this is great.
Thanks. So this is something that kind of confused me when I first got into ECGs, right? So you're reading the books, and the books are great, and everybody has a different perspective, a different viewpoint. And I would say, read at least 5 books from different people on a subject to kind of get a different viewpoint because they all kind of have really good things to add and it just makes you more enriched in your knowledge. So one of the things was the arrhythmia descriptors, right? Where we have SVT versus VT. When I first started writing one of my first training programs, I consulted a physician. I'm like, how do you guys break down arrhythmias? And he's like, it's narrow versus wide. Well, the book I was reading talked about SVT versus VT. And then another EP book talked about mechanism of activation. So there's really three main camps. But I think in sort of the ER setting, the early learning setting, I would either say it would either be SVT versus VT or narrow versus wide. Narrow versus wide doesn't always work in SVT versus VT because what you talked about earlier, accessory pathways. You have some accessory pathways that are considered SVTs that can be wide, and there's a couple different reasons for that. So as you learn real quick in medicine, in cardiology, in electrophysiology, almost in life, right? There are exceptions to every rule. So I'm glad my chart people can't really chime in here because I consider myself the exception to almost every rule. It's pretty funny. So hopefully these graphs kind of break it down for you. SVT meaning it's supraventricular. It's happening from above the ventricles. And then here in red, you got your VTs. And so again, another way is narrow versus wide. So wide being anything greater than 120 milliseconds. Some literature says 100 milliseconds, really depends on who you read. There's going to be some differentiation anywhere from 15 to 20% amongst the literature that you read. It really just depends on who you're following. And then mechanism of activation. I won't get too much into that. When you get into EP, that's more of an issue. And I'll show you some examples of what that is going forward. Regarding SVTs, again, just kind of blowing up that graphic and being able to differentiate SVT from VT is kind of a big deal because we're really concerned about VT rhythms. They tend to be a little bit more lethal. Your cardiac outputs, don't sustain as well. So it's a really quick down and dirty way to kind of look at the complex to kind of say, if it's narrow, great. If it's not narrow, I kind of get more scared. I want to pay attention to it more and see what's going on. So does this make sense? Do you teach it this way or which way do you teach, Jen, as far as classifying arrhythmias?
I like the narrow versus wide as our big question. And actually, it's funny you should mention the SVT with the Baron-C. I think that does mess people up a lot because then you're in that other ballpark. But I actually start it pretty basic with them and do the narrow versus wide. And then later, if they want to, they can go on to the more advanced stuff. But hearing it from your perspective is also cool because you get to actually see what's going on live inside the heart where we have to guess on the outside of the heart.
Yeah, I mean, in some ways, you're, within the, I'm kind of talking about the ER piece of it, you kind of decide what's kind of going on from a general perspective, and then they kind of get referred to us if the arrhythmia keeps perpetuating, and you're right. And we're lucky we get to see it live. It's really kind of cool. So if you guys get a chance to stop in the EP lab and just hang out for a few minutes, I highly encourage you to do it. It's funny. A lot of people, if you ask nurses or PAs or NPs that have been around cardiology for a long time, a lot of them say they don't like EP, but the reason for that is they haven't been given the education to thrive inside there. If I was to take you to Greece and without ever teaching language and say, go thrive, that's going to be kind of hard to do, right? So you want to take some lessons to learn the language before you get inside there. And once you start to do that, EP becomes really fun. You get to have more of a participatory part of the patient's healthcare and outcome in EP compared to some of the other things. I'm biased, of course, but we'll go forward from there. So a couple of descriptors again. Jen's done a really good job of breaking down what's going on here. This is what's going on in the atria, and narrow versus wide, SVT versus VT. And then we talked about it earlier. We talked about let me get to the next slide here. We talked about mechanism of activation. So in EP, we're always concerned about what's causing this arrhythmia. And there are three main mechanisms of activation. You have something called automaticity, we have reentry, and then you have triggers. So automaticity is where cells like the SA node just begin to fire on their own. So when we run into that, we want to see what's causing that. Where is that at? Is it normal? Is it abnormal? And then we chase it down. Reentry, your entrant rhythms we talked about. You have your AV NRT, you have your flutter, you have your AVRT. Those are your entrant rhythms. And then you have triggered. And those are some of your VTs. VT is kind of all over the place. It's actually manifests from all three mechanisms. So that in EP, we're looking to see what the mechanism is and then define it. And then if we could sort of disrupt that mechanism, the idea is that we free the patient of the arrhythmia burden caused by this mechanism of activation. So not so much necessary to know from an EKG point of view, but as you dive in deeper, it really starts to make sense what's happening from the ECG point of view. Automaticity, here's an example of what you'll see, right? AFib, sinus tach. I'm curious, Jen, everybody kind of puts AFib in a different place, and I'm curious how you teach that. Would you classify AFib as an SVT or not? I'm curious.
Honestly, Joe, we don't even go that far in our world, just because it's hard enough for our newer folks even to just identify AFib. And we want to make sure our priorities are like, make sure they don't stroke, do a CHADS-VASc, and identify the AFib. And the biggest battle actually for us, Joe, is identifying 2-to-1 atrial flutter that they think is sinus tach. So if you have any pearls that, obviously you're so in a good place because you can just look, right? Where we have to just guess, and it is a tough one. And that's, Joe, I think, honestly, the scariest thing for a provider, someone who's at a heart rate of like 140, 150, and, maybe they're in pain. So you think about sinus tach. How do you really differentiate 2-to-1 flutter?
This is what we get to do in the EP lab, is kind of differentiate that by looking at what's happening in the atria versus what's happening in the ventricles versus what's happening in the AV junction. And so we put different catheters inside there. So I know we got literally just a few minutes left. So I'm going to jump ahead to what it looks like in the EP lab as far as that's concerned. So I'm going to jump ahead here. So what is it that we're really doing in the EP lab? What we're doing here is, because I can talk about this all night and I probably don't give myself enough time. I'm going to jump around here. So what we're doing in the EP lab is we're taking what you learned here in your ECGs. This is what's called a surface ECG, as you've been studying through Jen's course. What we do in the EP lab is we break that apart into what's happening in the atria, what's happening in the AV junction, and what's happening in the ventricles. And the way that we do that is you do that through putting catheters into the heart. So here's your heart, and through the right femoral vein, the venous side of the heart, we put catheters up there, which are electronic wires. They have electrodes on the tip. And what we do is we're measuring the electrical activity inside the patient's heart. And what we're doing that is putting that here on the bottom set of screens, and we're breaking out those electrograms, and we're looking at what's happening specifically at different parts of the tissue. So where I would say the ECG shows you a summation of cardiac activity, which you get from the leads that are on the patient's chest, EP is showing us discrete signals from inside the patient's heart. So in the EP lab, we look at all of these things. So what we're doing here, hopefully this graphic kind of breaks it down for you a little bit more. For basic ECGs, we put the leads in the heart, on the patient's chest, and we get electrogram, and this is what we have here in the top. And EP, we have ECGs as well, house monitors, but we also have the catheters. So we put the catheter inside the heart, and then we plug it into a big fancy EP recording system, and then it spits out these electrograms that are specific to the patient's tissue. So we put one close to where the SA node would be, put one to where the His would be, one inside the ventricle, one in the coronary sinus. And so this is what it looks like in the EP lab. So these are static images, but really this is what it looks like. So things are going at this speed, and you're trying to figure out what the rhythm is. So we have the luxury of hitting pause and recording it and breaking everything down with calipers, electronic calipers, and writing the figures down and comparing baseline versus what's happening in real time versus down the road, post-op, things like that. So that's what's happening in the EP lab. Again, we get this information by putting a series of catheters throughout the heart. Here's one by the SA node, right? This one goes inside the coronary sinus, which tells us what's happening on the backside of the heart, both from the A perspective and the B perspective. And then we put one here in the His, and then the right ventricle. So what we're doing is you're trying to create a word picture, just like you do with ECG. Here's your surface ECGs, which you spend a couple of days reviewing. In EP, we want to kind of translate these waveforms to what's happening here inside the heart. So what we're learning to do, I'm showing you now what is normal. And this is where I was saying, if somebody's in EP or they want to go into EP, like burn this image into your mind, because going forward, this is how you decipher normal versus abnormal. In ECG, Jen starts off with showing you this is normal sinus rhythm. This is what a P wave looks like. This is what normal QRS without a Q wave or wide looks like. And so in EP, this is what a normal heart looks like when we start the study. Now they come to us because they don't have this, or something happened, and we got to explore that. We break everything out into different windows. We have our atrial window, which is hosts your P wave. Then you have your His, which shows you what's happening from your AV node, and then your ventricular signal. So all this happens at EP lab, and we get to sit down and run this machine. We get to see what happens live. We get to take snapshots, take some measurements, and then we have a cardiac mapper next to us, which any one of you can get a job in cardiac mapping right now. just call my partner, Stephanie, talk to Regina. We can put you in somebody who would hire you right now to be a cardiac mapper. So, I mean, everybody needs somebody. So that's all I have. I can keep going probably for another 20 minutes off my slide deck, easy, but I know we're short on time. I want to respect your time. And with that, I always like to conclude by saying thank you and Viva EP. So
Viva EP.
That's all I got.
Well, Joe, that was phenomenal. You got a lot of love on the Facebook group as well. People are just super stoked. Excellent, Joe. Lots of good comments. So I don't know about you guys. Why don't you put in the chat for me? Should we have Joe come back again? Why don't you guys put in the chat? We want to have Joe come back again. It's going to be, you vote, you get what you want, guys. So you tell me. Okay.
Anytime. However we can support you and your learners, we'd love to be a part of anything you do. So I love this stuff.
If people want to find you, Joe, if they want to be a mapper or if they want to learn more EP, I know you have some free resources even. Is there a website you can type in the chat for them?
Yeah. Let's see if I can bring it up and put in here. Chart Healthcare Academy. One of the other things I wanted to talk about, there is a ECG exam out there called the CRAT. And the CRAT is for anybody who wants to be proficient in just basic arrhythmia. And I would encourage anybody who's in school or you want to differentiate yourself, go take the CRAT. You can go to CCI. I'll see if I can put in a couple links. If you want to talk for a couple minutes, I'll bring those up.
Yeah, I'll do the
type those inside
scholarship.
there.
Yeah, if you can type them in the chat and then.
So I got the links for you, hon.
Okay, perfect. Yeah,
Regina,
if you can put inside the link to our website, we'll get some really cool articles on there. We're our whole focus is training people for EP, training people for pacemakers and professional development. And if we can be a part of your credentialing journey, let us know. And we just love this stuff. So however we can support you, that's what we want to do.
It looks like Dominique says, if you have the slides for reentry and triggered mechanisms, that would be great. I don't know if your slides are available or not.
Yeah, I'll see if I can get some. I gotta run it by my team, of course, because everything's copyrighted, right? But let's see what we can get out there. Slides for what was that?
Looks like Dominique was interested in the re-entry and triggered mechanisms of action.
Okay, mechanism activation. Yeah, I think that's an easy one we can get out there. Yeah,
okay,
for sure.
Cool. All right. Well, Joe and Regina are putting links in the chat if you want to connect. Michelle says, love the EP lectures. It's an area we never spend too much time in. And they love your energy. So this is great. I think you're probably going to come back, Joe, is what the fans are saying. So we'll have to talk about that. But in the meantime, let's cross our fingers for everybody who entered the drawing, because we're going to go ahead and pick our scholarship winner. Joe, you get to be live for this part.
All right. Yay.
See who's going to win the prize. So good luck, everybody. Fingers crossed. Our winner is Jacqueline R. So I didn't have enough room to write your full name, but Jacqueline R, I do think you're probably still live with us. Jacqueline R, you're the winner of our 30-day scholarship. So congratulations, Jacqueline. So reach out to me in private messenger. Yes, Jacqueline Renenberg. I better get to know your name well, because you're going to be spending 30 days with us in our program. So welcome in. And message me on Facebook so I can connect you with the group. If you didn't win the scholarship, the links will be in the group right after this chat. And we'll definitely see you inside. And I just want everybody really quick before Joe hops off to give him some love. Hashtag Joe. Hashtag Joe. I'm hashtagging Joe. We're grateful, and thanks Regina for being his wing woman and making sure everybody got what they need and getting a lot of love. So you guys, it's been a pleasure hanging out with you tonight as always. And we'll be seeing you again tomorrow for our last session at 5:30 PST. And Joe, it sounds like you and I will be talking about you coming back. So
yes, I'd love to. Be fun. Fun stuff.
All right. We'll see you guys later. Have an awesome night. Thanks again, Joe. Bye.
Bye.